Good morning, everybody. Good morning, everybody.
Morning.
Good morning, doctor.
Yeah, we could
Good
unmute
morning,
ourselves.
doctor.
Good morning. We could unmute ourselves for the initial couple of minutes.
Good morning, doctor.
Good morning. While we try to introduce ourselves. Okay, so I will go first. Okay, and we'll take it one after the other. I am Dr. Ikile. I am the gynae who will be taking today's topic. Okay, so one after the other, please. Let's please introduce ourselves.
My name is Deborah Makinde.
Okay, Deborah Makinde. Okay, thank you. The next person, please.
Hello, everyone. My name is Oriyomi Akinseiwa.
Okay, Mrs. Oriyomi Akinseiwa, you're welcome. Okay, the next person, please.
Good morning, everyone.
Good morning.
My name is Olamide Adedeji.
Oh, Mrs. Olamide Adedeji, you're welcome.
Thank you, sir.
Good morning,
Hello,
everyone.
Hello, please go ahead.
Okay, good morning, everyone. My name is Ifoma Arinze.
Okay, you're welcome, Ifoma Arinze. Do we still have anybody else on the?
Good morning, my Chiamaka Dozie answering.
Okay, Mrs. Chiamaka, you're welcome. Anyone else?
Yeah, possessive.
Anyone else?
Good morning, everyone. This is Flora Oriyomi.
Okay, Mrs. Flora Oriyomi, you're welcome.
Thank you.
Good morning, everyone.
Okay.
Chamaka Okolonkwo. Chamaka Okolonkwo.
Oh, Mrs. Okolonkwo, you're welcome.
Thank you.
Okay. Anybody else?
Good morning. My name is Debbie Abodunrin.
Okay, Mrs. Debbie Abodunrin, you're welcome.
Okay.
Anybody else willing to introduce themselves? Okay, I can see that we are about 18 participants and counting. This way is going to go. Okay, I will mute everybody now, and okay, I've muted everybody. I will take about 20 to 30 minutes of today's topic. Following that, I would I'll unmute every one of us and we'll take some questions. Okay, so you could note down some questions as the topic goes on. And also, if for whatever reason you have other questions that may not be related to this topic, please feel free. It may be one of the only opportunities you have to dispel rumors, to clear your doubts, and to improve on whatever you may have read up in Google. So this topic, what is the time? 11:04. Okay. So this topic is pain relief in labor. It's a very important topic, and we all know what labor is. For those who have gone through labor before, they will understand and know the practical issues that comes with labor. Labor, as we know, is the onset of painful, and the operative word there is painful, uterine contractions that ends up in the woman delivering. So the operative word there is painful. And when patients come into the clinic and at 36 weeks, I'm trying to run through labor with the new parturients, that is the first timers who are undergoing labor for the very first time, I try to explain to them the concept of the pain associated with labor. as different from what they have been having before. That is because from about 5, 6, 7 months, a woman starts to feel what you call Braxton Hicks contraction. Braxton Hicks contraction. This contraction, as I always explain to them, is relatively painless or at most uncomfortable. But it is never, never, never painful. That is Braxton Hicks contraction. However, when the pain of labor is going to set in, it is going to be very painful. And I always say, it has been described according to the Guinness Book of World Records as the second most painful pain ever. Second most painful pain ever. So in a pain scale of 1 to 10, it is obviously going to be approaching close to 9 to 10, because it's actually very painful. And when this pain arises, women in labor obviously tend to make hasty decisions, tend to say things obviously they do not plan to say ab initio, which obviously they will regret saying that, oh, why did I curse my husband? Why did I cause the whole setup? Why did I say things that I shouldn't have said? And that is the reason why we are taking this topic today, pain relief in labor. No, in time past, the African mind, or our grandmothers, our mothers, we want you to be a strong African woman. And being a strong African woman may suggest, they tell you that a strong African woman does not do cesarean section. A strong African woman is meant to pass through that pain of labor. Pass through that pain of labor. But I put it to you that that is nothing. That does not make you a woman, neither makes you a man, actually, if you are able to pass through the pain of labor. Labor should be a welcome experience if handled properly. And the only reason why labor becomes something very scary to our young women is only because of the pain associated with it. So if for whatever reason we are able to abolish, reduce, mitigate that pain, then obviously the woman will feel very happy, not only for that experience, but to also come back and pass through that same experience again. So far, pain has been taken away. And actually, several studies have shown to us that if pain is actually taken away, then the overall experience is palatable to the woman, and she's able to bond well with the child. And it also reduces, please mark this, it also reduces from several studies, which is empirically verifiable, that if a woman is able to have a pain-free labor, a pain-free labor, then such a woman has a very, very reduced risk of postpartum depression. That may be another topic for another day, postpartum blues, postpartum depression, postpartum psychosis, that is depression after delivery. It has been linked with the pain a woman will pass through in labor. And you will see women screaming in labor, oh, I'm never ever going to come back here again. I'm never ever going to undergo labor again. I will never come back. Obviously, we know that she does not mean all this. We know she does not mean all this, but unfortunately, that is how she feels at that point in time. I'll quickly run through the several options of pain mitigation, or how to manage pain in labor. And we'll try to look at what is best for us in this day and age, and what is obtainable for all women everywhere, irrespective of who they are. Well, in time past, there was a concept of psychotherapy for women in labor. And such psychotherapy, psycho means trying to reach out to the mind of the woman. Therapy, whether drugs or anything, but mind therapy. So I'll put it that way: psychotherapy, mind therapy. And that will talk about teaching the woman about breathing techniques, how to taking deep breaths when the pain comes and breathe out, talking to the woman in labor. He also talks about hypnosis in labor. Hypnosis, whereby there's a lot of suggestion to your mind that this pain is just an ephemeral pain. It's a pain that is fleeting. And they're trying to work on your mind so that your mind tries to override the pain, because the pain is actually a physical pain. But psychotherapy is trying to reach out to your mind in a bid for your mind to do what? To override that pain. But we see a lot of drawbacks with psychotherapy, because as I'm telling you, this pain the woman is having in labor, which I have described as the second most painful pain ever that the woman is going to feel or is actually feeling, is a physical pain. So how would we, in essence, expect the mind to overcome that particular pain? Does it actually solve it? Several studies have gone to show that there has been a lot of dissatisfaction with psychotherapy. So it doesn't meet the needs of women. No amount of hypnosis, no amount of water baths, no amount of Lamaze techniques, which are breathing techniques that we say employed in labor, actually brings a lot of birth satisfaction. Because the issue about labor is that the woman must be satisfied with the process. We want a good baby to a satisfied mother. That is the goal of labor for all parturients, for all laboring mothers everywhere in the world. A live baby that comes out fine and a satisfied mother. It's of no use. You can bring out a good baby and the mother is totally dissatisfied, not satisfied with the process. That may scar her for life, may push her to depression, and could also cause a lot of marital disharmony between her and her partner, because to her mind, it is you, the man, that has put me into this problem. So our aim today is to try to walk you through what can be done to make the labor experience very, very satisfying for you. So I've talked about psychotherapy, and I've talked about the dissatisfaction that women have gotten from psychotherapy, and they realize that, oh, it doesn't actually work for us. It doesn't meet our needs. It doesn't do what it says it's going to do. So people started looking at other medications to try to see, okay, if we give some medications, can it also help or abolish pain in labor? And one of those medications is the use of some certain injections that can be given, one through the buttocks or through the veins, to try to help pain relief, or try to help the woman bear pain. And some of those drugs are some drugs that you know. One of them could be the use of a sedative like diazepam, which you know as Valium. Some people have touted the use of, oh, let's use that. No, if the woman is drowsy in labor, maybe she won't really feel the pain. But the problem arose with diazepam in the sense that it will cause a lot of depression, because the woman is sedated. She doesn't know what is going on. She doesn't know what process is presently going on. And you know, diazepam can, Valium, also pass through the placenta, meet the baby. Just as the mother is sedated, the baby is also sedated. The baby is also very, very drowsy. So that does not meet the need. And you see, nobody wants to, we already said at the beginning that We want to deliver a good baby to a satisfied mother. Now, the mother is sedated, is drowsy. The baby comes out. The baby is very floppy. There is no agility with the baby when we use diazepam. And the baby has some depression. It's difficult to make the baby cry. The baby feels so sleepy, and the mother starts to get so worried after she has put to bed. So it was found out that this is not a good agent to use to help for the woman in labor. Some analgesic options also include something like opioid analgesics, which is given to women through the buttocks. But just like with diazepam also, the analgesic effect, that is the pain relieving effects of these injections, such as morphine, did not actually meet the need of the woman, because the pain associated with labor was so much higher than what those medications could meet. So it never actually abolished the pain for the woman. It never actually took away the pain. And very importantly, when we decide to use some of these opioid analgesic, I already gave a very popular choice of opioid analgesic like morphine. Others are petidine, pentazocine, meperidine. All these things are still opioid analgesics. And usually, if I think that a woman is going to deliver in the next 2 to 4 hours, I do not want to give opioid analgesics. Meaning that if a woman is about 7 centimeters, I am afraid of giving opioid analgesics or even diazepam. And why? That is because it also passes through the placenta, gets to the baby, and causes the baby to be depressed in the respiratory system, meaning that the baby does not cry well, does not breathe well. And that is, so it means that from 7 cm, the woman is left alone with the pain, nothing to mitigate, nothing to reduce the pain of labor. That obviously does not essentially meet the total pain-free relief we expect in labor, because we think that if a woman is at 7 centimeters and she's going to 10 centimeters, then that means that for the next 3 hours, this woman is screaming, this woman is shouting, she's making a lot of sin, essentially because of pain. And is she justified? Obviously, she is very, very justified. And nobody wants to, it's like somebody putting a blade to my skin and you're telling me not to shout. Obviously, I will shout. I will shout. It's not as if I have leprosy in that arm that I do not have a feeling at all. I do not have leprosy, so obviously I'm going to shout. And we don't want women to scream down the whole house and for everybody to know, I'm in labor, please see me. No, there are very, very good options that are available for us. You can say I'm mentioning these medications and I'm discounting them. That is because from experience, we've seen that the opioid analgesics, the diazepam, the psychotherapy, I have just very limited value. Because it's just like you go to a hotel, you want good satisfaction, you want total satisfaction. You go to lodge, you want everything to be where it should be. You want the service to be beautiful. Same thing with the use of pain relief in labor. Opioid analgesic does not meet the expectations that our women want. And as such, people started thinking of more ways by which we could alleviate the suffering of women such that they enjoy labor and possibly come back. Another option that women do have in labor is the use of gases, whereby it's put like a face mask a face mask is put over the face of the woman, especially directly over her nose and mouth, and she has a control in her hand. And as soon as she tends to start to feel the pain of labor coming, that is when she's now admitted. She presses a nozzle and some gas comes into her nostrils. And when that gas comes, that gas knocks her out for the 40 to 1 minute, sometimes as up to 2 minutes, when that pain of contraction is coming. Because what actually causes the pain of labor is actually when the womb contracts. So the woman takes that gas, and once she takes that gas, it helps to resolve the pain. And because that gas makes her drowsy, almost immediately, her hand leaves that button and no more gas is coming to the woman. And what will wake her up again is when another contraction pain comes again. Oh, she does, oh, let me press the gas again. She presses the gas. That dispenses some gaseous substances through her nostrils. It knocks her out again. But the problem with that gas is this. As she's inhaling the gas, some are escaping through the sides of the face masks and enters into the room in general. So that affects the nursing staff, the labor ward staff, the doctors who are coming to care for you. And obviously, you don't want a doctor who is coming to manage you in labor. You don't want the midwife who is coming to manage you in labor to get knocked out with these gases. Because if the doctor is knocked out or the caregiver, then who cares for you? So that's why many labor centers, both on either side of the oceans, do not readily advocate the use of gaseous substances. And what they use is the laughing gas. They hardly use that in other climes, and obviously not also in Nigeria because of these side effects of gassing up the whole labor ward suits. And everybody feels drowsy, and obviously you want your caregivers, your doctors, your nurses to be on top of their game and to be very, very alert. So as such, that did not really peak with many gynecologists. So that led the doctors to what can we do to really tackle the pain associated with labor. And that will take me to the use of epidural anesthesia. Epidural anesthesia. You will see I use the word epidural anesthesia, not epidural analgesia. That is because with analgesia, just take it as analgesia means just like when you take your paracetamol, your ibuprofen, your diclofenac, you want to try to modulate the pain. And that's what analgesia does. It only modulates pain perception by you. It modulates pain perception by the woman. And that is what those gases we do, your diazepam, your pentazocine, even your morphine. That is what it's going to do. You try to modulate the pain perception that you are getting. That's what analgesia is about. But with epidural anesthesia, because there's a difference between analgesia and anesthesia. We talk about general anesthesia, spinal anesthesia, but now epidural anesthesia. Anesthesia talks about a total loss of sensory perception by the woman, as different from analgesia. Analgesia is about pain modulation. Pain modulation. Modulation of pain perception. There's pain, you perceive pain, but it tries to modulate that perception. But anesthesia is a total loss of sensory perception. Total loss. So because when something pricks my toes, some nerves will carry that pain to my brain. Obviously, I'll take my toe away. That thing is painful. Analgesia will only modulate that perception for you. But with anesthesia, there's a total loss of that perception. And that is awesome for the woman in labor. If I can knock off a total loss of sensory perception. So there's no modulation. Modulation is, you are trying to caress the pain, but this knocks out pain totally. And that is where the issue of epidural anesthesia comes in. And I'm going to spend some little time there, and then I'll take some questions. Epidural anesthesia simply talks about giving you a little needle at your back. For those who have had cesarean section before, we know about spinal anesthesia. It's about the same technique, but a little bit different and a little bit more technical. And that's why we have one of the best hands that come do that for us here in Mother and Child, by placing a little, very flexible and tiny catheter into our back once he has made a puncture at the back there. And once he does that, then that catheter is plastered down. It's just like when you come in and somebody wants to put a drip for you in the hospital. It's not each time you need a drip, they will come and pass something through your vein. They already pass that cannula into your vein and they plaster it down. So at each time you need fluid or you need drugs, they will just come, unscrew the cap and give you the injection. That is the same way epidural anesthesia works. That cannula or that tubing is passed through your back and it is plastered down. So every hour, the anesthetist, who after passing that cannula, sits with you and spends time with you. That is because when a woman is in labor, I do not essentially know. I may have an average idea of when she's going to put to bed. On the average, I would expect that, okay, when the woman comes in active phase, and we know the active phase of labor starts when the woman is 4 centimeters dilated. When she is still from 0 to 3 centimeters, we say, oh, she's in the latent phase. Let's hold on. When she's in by 4 cm, then we'll transfer the woman into the labor ward. And from that 4 centimeters to 10 centimeters, I will expect her to have her cervix open up or dilate at 1 centimeter per hour. So in essence, I'm expecting about 6 hours for the woman from 4 centimeters to 10 centimeters. And for some, it could push all the way to 8 hours to 10 hours, because if you're a first timer, that progress may be a little slower than somebody who has delivered before. And the obstetrician or the midwife takes cognizance of this. So it means that the anesthetist who is doing the epidural sits with you. He's there in the labor ward, sits with you, because he's the one that passed the catheter. He's the one that passed the pipe into your back. So he monitors what he has done. And every hour, it gives you a little fluid through that pipe into your back. And that fluid contains some drugs that will knock out totally pain perception by the woman. And when that is done, we've seen women who are actually watching films when they're in labor, both in Adeni Jones and also in Bankole. They're watching films, they are on Zoom call or on Skype with their partner, if the partner is not around, or with their friends, because they're in labor. And they ask them, I thought you said you're in the labor ward, but obviously she's in the labor ward. Doesn't essentially mean that she should be screaming down the whole place. So the process, pain is not there anymore, and she's enjoying the whole process. And such a woman, mind you, has a higher chance of vaginal delivery. Why do I say so, if you ask me? That is because when I am in severe pain, I've already told you that a woman in labor is in severe pain, second most painful. So sometimes having to examine the woman to say, madam, can I please check you to know how many centimeters dilated you are? Because you must check regularly to see whether the woman is progressing. You also want to listen to the fetal heart to see whether the baby's heart is doing fine. But I can show you, as we have seen severally, and as some of you will also testify if you have gone into labor ward sometimes with your friends, with your sisters, or maybe you have delivered before, that your cooperation at that time is maybe 20-30% because of the pain. Nobody can blame the pregnant woman. It is the pain that is the problem. So she's not cooperating. For the midwives to examine her by doing a vaginal or a cervical examination for her to know how far dilated she is. Sometimes she won't allow them check the baby's heart, whether the baby is breathing well. They won't stay in one place. They'll be rolling around the whole place. And I've seen some women hide under the bed because of pain. And some have even run away, stuck naked from the labor ward, all due to one singular reason, pain. And sometimes, we put up a fluid, because we want the womb to contract very well. Because we know that it is when the womb contracts very well that the cervix opens. So we put up a fluid and we add oxytocin. Please, what's up, everybody? Okay, I've muted everybody again. There are a lot of feedbacks. Okay. So back to what I was saying. I said sometimes we put up oxytocin into the fluid, all in a bid to do what? To make the womb contract better. Because I know it is when the womb contracts better that the cervix opens. If you are not contracting, I can assure you your cervix will not open. Obviously, it's not possible. You need that contraction. So sometimes we want to make that happen. So we put up fluids. And obviously, with the increase in the contraction, the pain becomes more and more severe. So such a woman, you'll bear me witness, obviously she won't allow anybody. I've seen some, they will tear off that drip. No, don't give me that drip. That drip is fire. That drip is causing me issues. But the drip is actually to help them. But the pain will not allow that to happen. And as such a woman, by the time she's like 7 or 8 cm, and the pain is so severe, she will just say, doctor, please come and take this baby out of me. Let's go for a cesarean section right away. So that's why I say, when a woman's pain is totally knocked out in labor, then she has a higher chance of having a vaginal delivery. That is because she's calm with the process. She allows vaginal examinations. She allows us monitor the fetus. And she allows us put up the drip to allow adequate contractions, which are monitored. So that tilts her to full cervical dilatation when she is 10 centimeters dilated. So in essence, I'm a very strong advocate, not a feminist, but I'm a strong advocate for women being comfortable. And labor is painful. And I'm a very strong advocate for pain relief in labor for all women. Though in some situations, some women may say, no, I don't want pain relief, I want to pass through it. Obviously, you respect that decision. But for majority of women, I know they will always want to have a pain-free labor. That is epidural anesthesia. Very wonderful, very beautiful. And the satisfaction in labor is very, very, very high after epidural anesthesia. And don't also forget that during the second stage of labor, that is after you are now fully dilated, and would they now move you to where you are going to push out the baby, the epidural anesthesia helps you. That is because if you never had epidural anesthesia and somebody is telling you to push a baby's head out of the vagina, the stretch of the vagina causes an intense pain. And some women could stay there because they are so afraid to push out because of the pain that they are feeling. But with epidural anesthesia, that second stage of labor becomes a walk in the park for them. Becomes very easy because they do not feel the pain. So it's easy for them. And for some women also, you know, as the baby wants to come out and the midwife sees that, or the doctor sees that, oh, I need to give this woman a little cut to make the baby come out, which everybody knows as episiotomy, you know, to cut the vagina a bit to open it up wider. That is episiotomy. Obviously, it's painful to give, and it's also very painful to repair. But with epidural anesthesia, that also covers through that process also. And even up to 1 to 3 hours after a woman delivers, still pain-free. That is wonderful. So by the time she's get to 3-4 hours after delivery, she's good and fine. The cut that the doctor or the midwife made has been repaired. Everything is fine, and she's good. But obviously, you want to ask that, what is the drawback to epidural anesthesia? What is the drawback? Just one that I will mention. And to me, it is, because everything is all about cost benefits analysis. It's all about the pros and cons, the merit and demerit of an action that is being taken.
No, man.
Somebody is also, sorry, I'm going to mute somebody else. Okay, I'm back. As I was saying, what has been said to be a drawback to epidural anesthesia? The only drawback that has been noted in literature, several studies written in textbooks, is that it may prolong a little bit the second stage of labor. And I already told you the second stage is when a woman is fully dilated to when the baby comes out fully. And why is this? That is because in the second stage, that is the stage where you are told to push down. Because you are not feeling any pain at all in your tummy, you essentially do not know when the contraction is coming. So you do not know when to push. But the medical staff can obviate that delay, can remove that delay by doing what? By putting a hand on your tummy and say, oh, madam, you are contracting. Please push down. So your brain sends signals to your abdomen and you start to push with your head that, okay, I'm told to push. So with that essential second stage delay, that delay in the second stage is not an issue anymore for our women. They push and everything is done. So some women will ask, at this junction, I'm going to try to, I haven't spoken to so many women about epidural anesthesia during their antenatal clinics, and they're raising some questions or some misgivings or some rumors they may have had. I will try to pick on some of those rumors and try to clear our minds of this. So maybe that is part of the question you meant to ask. So that will solve that question now. Number one, some women will say that if I do epidural anesthesia, does that not increase my chance of having cesarean section? The answer is no. It actually increases your chances of having a vaginal delivery. That is because you allow the doctors to put up the fluid and contractions are adequate. You allow the nurses to examine you. There are no issues. So it actually improves, that is the word, improves your chances of having a vaginal delivery as against a cesarean section. So it does not in any way increase the chances of a cesarean section. Two, some have said that I usually had it, some people, my sister had epidural, blah, 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 and that because of that, she's having severe pain at the back. I now tell them that the pain you feel at your back is no different from the pain of when somebody puts a line into your hand and gives you a drip. But the needle is as tiny as that. It does not cause chronic back pain at all. And neither does it cause, epidural does not cause headache. What causes headache is spinal anesthesia. And in spinal, what happens is that they puncture something at the back and allow some of the fluid in your back to flow out. That usually happens during cesarean section when we do spinal. But that does not happen because in epidural, they do not puncture that bag at the back. It's actually outside of the bag that you inject your fluid. So there is no increased risk of having headache following epidural anesthesia. So in general, epidural anesthesia is very, very beautiful. And the truth of the matter is that for many people who have gone to deliver outside of the country before Corona became an issue, and before Trump became who he was and blocked the road for so many of us, in all labor wards in the US and the UK, epidural anesthesia is what is being offered to women, and as much as 90 to 95% of women take it up, and they are satisfied with the overall process after delivery. And that's what we offer in Mother and Child, epidural anesthesia. And you want to ask, oh, okay, what is the cost implication for epidural anesthesia? In the time past, we would it was 250,000, but after discussing with the management, we realized I wanted more women to take up this epidural anesthesia, and so they can benefit from what they would naturally benefit if they had gone to the US to deliver or the UK to deliver. And we have brought it down to 200K to at least take off 50K to make more women take up the anesthesia. And so many of them are taking it up, and the reviews have been awesome. They are so happy, and they wonder that, so why was my mother saying that I should go through labor like that? So this is what people are enjoying. So obviously it's quite a woman going to come in the next 1 year to a year and a half, because she obviously enjoyed the whole process. And that is what we are bringing to the table, epidural anesthesia. I'm going to take questions at this junction because I think we have about 17 minutes more. We'll take some questions. As I said initially, if your questions are not your questions may not be restricted to epidural. You may have 1 or 2 questions you may want to ask. It's an opportunity for you and any other person to benefit. So if you want to ask your question, please, you can unmute yourself. You can unmute yourself. I would I'll answer your question. So this is question time. If you have questions,
hello,
please. Yeah, your name, please, if you're going to ask a question so everybody knows who we are talking to. Please, yeah.
Okay. Hello, good morning. My name is Uloma.
Okay, Mrs. Uloma.
Okay. Yes, my apologies. I joined in late and I know I've missed a lot. So I would like to ask, this session, is it recorded so I can go through it?
Yes, it is being recorded. Okay. So I'll hand it over to the business manager went through, and she will get it across to all of us so that we can obviously listen and listen again. So that even though it comes that, okay, you want to come ask your questions in the clinic, obviously we'll be more than happy to receive your questions. Okay? Yeah. Any other question?
Hello. Hello.
Yeah,
Okay,
hello.
My other question is this.
Is it Mrs. Uloma?
Yes, it's still me, Uloma,
Okay.
yes.
Yeah.
Okay. My other question is this. I'm a first-time mom. about 25 weeks gone. And I was having a discussion with a friend of mine, and she told me that most times you have to make the hospital know that you want to, deliver in their hospital. Like sometimes they just assume you're coming there for antenatal. So is that applicable to mother and child? Do I have to let you know that I want to deliver a mother and child hospital, and I also want an epidural? Do I have to make a prior request for that? Or does it just follow because I'm taking antenatal there?
Okay. I will say this. I would expect that if I am doing antenatal for you, please, if you are not asking questions, you could mute yourself and unmute if you need to ask questions. A lot of background noises. Okay. Usually, I would expect that if I am taking an antenatal for a pregnant woman, I wouldn't in any way think that she wouldn't want to deliver with me, because the gynae who has your history makes everything easier, both for the gynae and for the doctor, for both the gynae and the woman. So you don't have to tell me ahead of time that, oh, I'm going to deliver with you. I would even expect 100% that you are doing antenatal with me. Obviously, you are going to deliver with me. Okay, so I believe that you are going to deliver with us. And actually, we've seen women walking, maybe having antenatal somewhere else and come to deliver. Once a woman comes in to deliver, I welcome all women. We welcome all women who want to deliver. Your HMOs you could be elsewhere, and HMO say, please go deliver a mother and child. I will think what I do is just to get a quick history from you about your previous antenatal records from the previous hospital. You tell me the scans you have done, the tests you have done. I may likely repeat mine, but I just want to have an idea of what has been going on in that center. So we take all women, whether you did antenatal with me or with us, or if you just came in for delivery. And as regards the epidural, do you need to tell your caregivers ahead of time that yes, you benefit from epidural? Usually by 36 weeks, when I'm discussing birth plans with the women, we're discussing, okay, what are you expecting, this and that. There, of course, the issue of epidural comes up. And for those, it's either of two ways. There are some that, because they have had epidural in the US or UK before, obviously they know the process and they are more than happy to undergo the epidural. So they do what? They tell me, oh, I'm interested in the epidural. And because most of them do have my number, they will just say, okay, I'm going to call you when I'm coming to the hospital, and so that we'll get the anesthetist around and ready. But obviously there will be some who have not yet made up their mind, and who obviously will think that, is it not labor? My mother passed through it and she has 7 children. But during that very early stages of labor, the pain will get so far to her mind, she'll just feel, no, this is horrible. Can we have an epidural? Obviously, we also meet the needs of such women. Okay, so there's no issue whether you make up your mind before or make up your mind on the day of when the labor starts. But most women have my number, and they always try to reach me before they get into the hospital, so that we can get the anesthetist around to do the epidural.
Okay, thank you very much. Thank you.
You're welcome. Yeah. Any other person?
So how do we get your number? Like first-time moms like us, how do we get your number?
Oh, okay. I'm going to call up my number now. And I know some people always say, but I will try to call you, you couldn't pick. Obviously, sometimes I could be busy in the clinic, busy with everything. And once I'm in the clinic, I love to give women 100% attention when I'm attending to them. And as such, I may not be able to pick your calls, but please, it's a WhatsApp number. Send me a message on WhatsApp, and definitely I do respond to messages.
Okay.
Earliest available time, I do respond. Okay, so my number is.
Danny, maybe you should drop it on the chat box. I think is.
Okay, I'll find a way to chat.
Oh,
box. Okay.
All right.
Okay, let me, and that's 0.
When they call it out, I will type it. I will type it for them.
Okay.
Okay,
080
sir. Okay.
Just call it out.
08034 976 376. Okay. So that is my number.
So let me call it 080 349.
Yes.
76376. Am I correct?
Please come again. The call was trying to come in, so I didn't get that.
0803.
Yes.
497.
Yes.
Oh, sorry. 6376.
Yes. Beautiful. Yeah. So that is my number. It's a WhatsApp number. So please, every woman is everybody can reach me on that number, and I will definitely respond at the earliest available time. So any other questions, please?
Yes.
Yeah, I want to ask a question.
Yeah, who is speaking, please?
Charis Oriaku.
Mrs.
My name Charis Oriaku.
Oh yes, Oriaku. Yeah, I do remember.
Yes, please.
Okay.
Thank you. So, I have I'm asking for like someone who has done CS 2 times, and the person wants to try vaginal delivery. Can epidural help that person to have an easy process through?
Okay. You know, today's topic was about pain relief in labor, and that means that I want to abolish the pain of labor.
Yeah.
But that is a totally different game when a woman has had 2 previous cesarean sections.
Okay.
The consensus, according to the International Federation of Obstetrics and Gynecology, which is an international body, is that the woman has had 2 previous cesarean sections. Then that woman must deliver, mark the word, must. She must deliver this 3rd baby by a cesarean section. That is because the risk of rupture of the uterus after 3 to 4 cesarean section is what? Is about 3 to 4%. But now you will not say, it's just 3 to 4%. But if a woman's womb ruptures in labor, before everybody runs around to do things, the woman may lose her whole blood volume in 10-15 minutes. And to that family, it's 100% loss. 3 to 4% is a very strong percentage. Yes, it's a strong percentage, and that's why the general consensus is after 2 is cesarean section. However, if she has had just 1 cesarean section, based on some factors, we may allow for her to have a vaginal delivery if she meets some very, very stringent criteria. And in such a case, epidural is beautiful. Whether previous CS or no previous CS, epidural works beautifully well for everybody.
Okay.
Yeah.
Thanks a lot.
You're welcome, ma'am. Yeah. Any other person?
Hello.
Yeah.
Good morning.
Yeah, good morning. Who is speaking, please?
Mrs. Folayo. Adebimpe Folayo.
Okay, Mrs. Is it Afolayo or Folayo?
Folayo.
Okay, so I should keep the A to myself.
Yes, sir. I want to know the effect of epidural on mother that has blood pressure.
Okay. You know, I said ab initio that when during the epidural, the anesthetist is always with you, obviously, for as long as you are going to deliver. Okay, because some people may wonder, oh, why that cost 200K? Is because the person is with you and he doesn't know when you are going to deliver. And epidural anesthesia, just like spinal anesthesia, may want to drop your blood pressure a little bit. Okay, and that is why the anesthetist is there to give you adequate fluid via the drip to bolster, to build up your blood pressure. Okay. So, may want to reduce the blood pressure, but with adequate fluid, your blood pressure balances out. And during epidural, when the anesthetist is there, he monitors you using the blood pressure machine to ensure that your blood pressure is within the range he wants it to be. Okay?
Okay. Thank you, sir.
Yeah, you're welcome.
I have a question.
Yeah, who is speaking, please?
My name is Deborah.
Deborah, Mrs.
Yeah.
Deborah, okay. Yeah.
Okay, so my question is outside the story because I clearly understand what you taught us today. So it's a different question.
Please go ahead, ma'am.
Okay, so I want to ask that why do they give us ferrous and calcium only and not folic acid being added to our drugs? I just wanted to know.
Okay, ma'am. Okay, ma'am. Some people have asked this question before when they come into the clinic, and you know what I tell them?
No.
I tell the pharmacy people to bring the carton of the medication, and I hand it over to the woman so that I won't be seen to be reading it myself. And I tell I tell her, oh, can you go see the ingredients that makes up that ramferon that is being given to you? And by the time she reads everything, I say, oh, I didn't know. Because to everybody's mind, once you see something red, you assume it is what? Ferrous. But the truth of the matter is that what is being given to you does not contain ferrous alone. But I know the sachet they give it to you in, it's a bit difficult to read the ingredients, okay? The composition of what is given to you, okay? But I can tell you here, very 100% that it contains ferrous. That's ramferon being given to you contains ferrous. It contains folic acid, it contains vitamin C, and it contains the B complexes. That is the vitamin B complexes. Okay, so it's not just ferrous. It contains all the things you also just mentioned right now. And that is because we realize that for women to take drugs in pregnancy will be an issue. So make that drug, we give them that single one. So they take it once a day, has all the things I need, and it meets their requirements. So it is not just ferrous, ma'am. It contains every other thing.
Okay, good morning, Dr. Good morning, Dr. Ikida.
Good morning.
Deborah Kolade.
Deborah Kolade.
Yeah.
Okay, please go ahead.
Okay, my question is about the epidural and HMO.
Okay.
Does the HMO cover that, or it's an extra cost?
Yeah, that's why I mentioned the cost of the epidural. The HMO does not cover it. And that is because, you know, this is, to my head, I believe they will think that, oh, this is Africa, let our African women go labor in pain. Okay, so the HMO does not cover it. Okay?
I think I missed the part of the price.
Okay, I thought it was initially 250K, but now after the management it's now 200K.
Okay.
Okay. Can I just make an input, please?
Okay.
I think going forward, if our women are interested in this, they just need to tell the HMO, and the HMO probably will increase the premium for delivery, and they will cover it. It is still on the long run.
Or probably if we can call our HMO, because sometimes they may not know, but if you call them and tell them what you want, it depends on the plan. Actually, it depends on your plan.
It has to be incorporated in the plan. So if it's
so it's possible to call them before then?
Yes, it's better to call them before then. And so that they will not be at the time of delivery that you're not
making that decision. Yeah.
We don't have time for that when we're already delivering. Thank you.
Okay.
Hello.
Okay, thank you.
Hello, this is Cham. I have a question.
Okay.
Please, I want to know the effect of calcium. Chamaka.
Okay.
Effect of calcium in iron absorption
example, like me, I'm trying to build my blood and I'm still taking calcium. So I don't really know the effects, whether the iron is absorbing very well.
Things that would help your absorption of iron. One, most times maybe on an empty stomach, but I can assure you that letting iron land into an empty stomach will cause a lot of irritation for you. So a light meal may help you with the absorption of iron. And also taking it with your vitamin C will help in the absorption of iron. And that's why it's always good to always take vitamin C when you are taking your ferrous. And that is what is in Ranferon. It also has vitamin C already there. So it aids the absorption of your iron. Calcium will not be detrimental to the absorption of iron for you, okay? Calcium good for good bones and things, that is fine, but will not be detrimental to the absorption of iron for you. But vitamin C is really going to help you in the absorption of iron.
Can I still take extra vitamin C, because the vitamin C I'm seeing there is very little?
How do you, okay, what's the milligram there?
75.0 mg.
75.0 mg.
Even folic acid as well is very little, 0.75 mg.
0.75.
0.75
mg, that is 750 micrograms. Well, according to the World Health Organization, we want our women to be on 400 microgram, and that is 0.4 milligram per day. Okay, so you can see that that 750 microgram or 0.75 milligram far outstrips the 0.4 milligram mandated by the World Health Organization. Okay. So in essence, I know why you're saying this. That is because those small folic acid comes as 5 milligrams. Yes. And in actual clinical practice, I will want to give 5 mg to a woman who is at a very high risk of having a baby with spinal bifida. That is a deformed spine for the baby. Okay, and that will happen if the woman has had a previous history of spinal bifida baby, or the woman is on some certain drugs, on anti-epileptic drugs. Obviously, I want to give her a lot of folic acid to counter the effect of those drugs. But in the generality of women, 0.4 milligram is more than enough to meet their needs. And the 750 is even an overkill for me, so it more than meets their needs. And for the vitamin C, the recommended daily intake, the 75 milligram meets much more than what is being given. However, if you need to build your blood for whatever reason, maybe you are less than 30%, and the doctor wants you to take double dose hematinics, like they want you to take your Ranferon twice a day, or I want to add a tablet of those little ferrous. I want to add some vitamin C for you because I know it's going to aid the absorption of that iron. So if you're not on double dose hematinics, what you have in Ranferon is okay to aid the absorption of that dose of iron in Ranferon. Okay?
Okay, thank you.
Can I just pass this comment on the question about calcium?
Okay, sir.
I'm aware quite a number of people talk about calcium chelating, or this binding iron when they get into the stomach. Well, if you have ionized calcium, well, definitely can bind ionized iron. So you can chelate, what you call chelation. And then in order to be careful, because we don't know other meals that you are taking that could have ionized the iron. So what you do is to separate the time you are taking the iron from the time you are taking the calcium. Don't take the two of them together so that the risk of absorption will not be reduced.
Okay.
Thank you.
Thank you.
Good afternoon, doctor. Please, I have a question.
Please, go ahead. What's your name, ma'am?
My name is Tomilola.
Okay.
Okay. I've heard a lot about the venice on babies, leaving the venice on babies when they are born for 24 hours. I just want to know the hospital's policy on this. Is it right? Is it advisable? Is that what you do here? Thank you.
Okay. No, the vernix, VERNIX, is that whitish looking coating on the body of a baby when the baby comes out. Okay, I'm only just telling the other woman. Okay, that is what the vernix is. Okay, and what does that vernix do? It helps the baby to retain heat in the body, to retain heat. Okay, our policy is not to keep that vernix. Actually, I've not seen it in many Nigerian hospitals, and I've been around. Okay, I've not seen that happen, and that is because when the baby is born, the baby is immediately put under a resuscitator, and that resuscitator where we resuscitate the baby is warm. That is because we put it on before the baby comes out, and that place is kept warm. So in essence, the baby does not lose heat. So there's no need keeping the vernix. So we'll clean the baby, clean the vernix away, and clothe the baby and put the baby under the resuscitator, and the baby is kept warm. So the need to keep that vernix obviously is no more there because the baby is kept under a warmer once the baby is out of the mother's womb.
And our weather is not as cold as we have in the temperate countries. So we already have the warm weather. So there's no need to keep anything warmer.
All right. Thank you, sir.
Yeah. Okay. Any other question? I think that we have, it's been a wonderful time talking to our women. And if you have further questions, obviously you have my number, you can send WhatsApp messages. And if we do see in the clinics, please, let's talk. And the business manager will send this recording so that we can go through it over and over again, also previous recordings. Okay, thank you so much. Stay safe.
Please check the chat. I've already given you the phone number of the business development manager, so you can contact her and get the previous recording. Thank you.
Thank you all. Have a beautiful weekend. Okay.
And thank
you. You too.
Thank you too.
Bye.
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 Thank you.
Please, let's get the number before you exit the group, please.
What number?
Okay, I'm the business developer.
I'm told it's on the chat, so I won't exit, so I'll allow you go to the chat. I went to end the meeting, but I would allow people to go to the chat and go get her number. Okay, her name is Loretta.
Loretta.
Yeah.
Let's see.